Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by gastroenterologist Dr. Vahe Shanazarian. Welcome. Thank you for joining us.
Thank you for having me.
Through RUMC Connections, you will meet the doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The Ambulatory Center and GI Endoscopy Suites at Richmond University Medical Center provide full-service ambulatory services for children and adults. Each year, thousands of procedures are performed by our experienced physicians, nurses, and technicians. Our 6 state-of-the-art procedure rooms contain the most up-to-date diagnostic and treatment equipment available, including sophisticated monitoring equipment for your safety. Thank you once again, Dr. Shanazarian, for coming back on and joining us today. Today, we will discuss irritable bowel syndrome and how people can seek relief and kind of combat this issue.
Yeah.
Can you please talk about what causes IBS and the potential treatment options?
So we're kind of still in this infancy stage of understanding IBS. It's improved greatly in the last decade or so, but we still have a lot of work to do in really getting to the nitty-gritty of it. Right now, we kind of think it's mostly related to the gut's bacterial genome, stressors, anxiety, things like that, because the nervous system, the way it communicates with the GI tract, and dietary. Those are the 3 of the kind of major things we try to focus on with IBS. That's how we try and kind of put little puzzle pieces together to help patients combat their symptoms of IBS. And there's so many different types of symptoms. So it's important to kind of look at the patient as a whole and decide what types of symptoms they're having and what is related to what. Is it 2 different things that we need to look at, or is it all kind of under the IBS umbrella and things like that?
Okay. Now, is there more than one type of IBS, or is it just kind of one main category?
So it's kind of one big thing, but it does get separated into irritable bowel syndrome with constipation predominance and irritable bowel syndrome with diarrhea predominance. And then there's the mixed disease, where it's kind of intermittently both.
Okay.
Those are typically the ones that patients come in. Most are one or the other.
Okay.
And then you have that kind of gray area.
Gray area in between.
That's more mixed.
Now, is this something that someone is born with, or is this something that presents later in life as people get older?
So it depends on, every patient will tell you different.
Yeah.
You know, they'll say, I've had these symptoms since I was a kid.
Okay.
This just started last month. You know, there's certain phenomena of like post-infectious irritable bowel syndrome where you go through something, you know, you get a food poisoning or you get some weird viral infection and your body is just confused. For a couple of weeks to months after that, you suffer through the symptoms and then it just kind of resets itself. Or antibiotics for a bacterial infection messes with your gut's biome. And your body's kind of trying to figure out those percentages of the different bacteria you have. And that will kind of typically resolve itself. Some patients are kind of stuck with IBS forever after that. So kind of look at it as a lifelong thing.
Yeah.
When you actually get symptoms is very patient specific. So it's tough to say.
It's not
honestly,
going to be the same
I
for
think
everyone.
we don't really have an answer for that yet.
Yeah.
But it can be a wide range of things like that.
Okay. Can you explain the difference between food allergy and food intolerance? Because I think this could be confusing to people with respect to their role in IBS. You know, are there any commercially available tests that you'd recommend to people with IBS to kind of differentiate?
Sure. So food allergy is like a systemic thing.
Okay.
Right? You eat an egg and your throat closes up.
Yeah.
Or you get a severe rash. You have trouble breathing, whatever. That's a food allergy.
Yeah.
That's more of like something pretty serious that you have to address and try to avoid because it could potentially be life-threatening for someone. Food
Intolerance.
Food intolerance.
Yeah.
I would say is more related to something like IBS. It'll give you like, it's more contained to the gut. So gas, bloating, constipation, diarrhea. Those are the things that we would categorize more as a food intolerance. Like someone who's lactose intolerant, right?
Yeah.
That's more of a food intolerance.
Okay.
Celiac disease with like gluten and everything, that's a little bit gray, but considered more of a food allergy because
Really?
you can get systemic effects from that.
Okay.
I personally haven't had a patient who's been like anaphylactic, which is like the throat closing,
Yeah,
can't breathe,
yeah.
from eating gluten.
Okay.
But, gluten, celiac specifically, not gluten sensitivity, but gluten intolerance, complete gluten intolerance. You can have fertility issues. You can have iron deficiency, anemia, or your blood level is a little low.
Okay.
Sometimes that's all you have in a
Wow.
patient. And then you do the testing and you realize, hey, they have celiac disease.
Okay.
So that's a way to differentiate. Commercial tests, unfortunately, are not great
They're not.
for food sensitivities, especially the blood test. I would say, honestly, the best thing to do is go to an allergist, specifically a physician who's trained in allergies. And they can do specific skin testing and other types of things that they do to give you the best idea of what you're more sensitive to.
Okay.
That'll kind of help guide what you should and shouldn't be having.
Okay. And would you say, so I think a lot of people tend to focus on carbohydrates affecting their IBS, but do proteins and lipids play an equally important role?
It's everything, honestly.
everything.
There's a diet called the low FODMAP diet that
Okay.
was developed specifically for patients with irritable bowel syndrome. That's probably a good diet for everybody to follow.
Yeah.
Because the way I have it broken down for my patients at least is there's a good column, there's a bad column. And it's mostly like ingredients, not like a dish, an
Yeah.
entree or whatever. It's just like typical foods. So
Okay.
it's broken down into like fruits, vegetables, liquids, meats, whatever. You try to tell them just have more from the good side, less from the bad side. See how you feel.
Okay.
Because again, even that diet is made for the general population. So something on the good side might bother you specifically, but it won't bother me.
Okay.
Something on the bad side might not bother you at all, but I will be in the bathroom all day, which kind of leads into one of the things I always ask patients to do is keep
Yeah.
a food journal. So write down what you ate, at what time. If you get symptoms, write down the symptoms and at what time.
Okay.
And then leaf through it once a week just to kind of see something that you might not think about that day. You're going to see it pop up 4 times in 2 weeks or a
Yeah.
month and realize, hey, maybe this thing is one of my trigger foods and I just didn't realize it.
So now if somebody is keeping a food journal, which I think is a great idea for something, somebody struggling with IBS. Now, what if it's a trigger one day and then another day they're totally fine? Like, do you recommend that it's something that they just eliminate from their diet completely, or do they continue monitoring and tweaking, eating it?
Yeah, I mean, I would say it depends on the severity of the symptoms they had.
Okay.
If it's something where it was just one time and they can't figure out any other reason for it, I would say cut it out for now. And obviously they had a severe reaction to it. Something where they were like, I couldn't leave my house for the day. I had to miss a birthday party. Like something that really bothered them.
Yeah.
I would say cut that out at least for a month. See how you feel. Did it happen again? Could it have been something else? Could it have been an ingredient in the
Yeah.
thing you ate as opposed to the actual thing you ate? It's a very fine-tuned game,
Yeah.
unfortunately. And the patients who are very in tune with it actually get really good at it.
Oh.
And the name of the game is not 100% symptom-free. It's just
Yeah.
not, unfortunately. It's decreasing the amount of time you're having symptoms so that your quality of life improves. You don't want to be the person. I mean, I get this all the time. I can't drive into the city because I'm afraid I'm going to have to use the bathroom. And then it becomes a mental block.
Yeah.
And then forget it. Like once that happens, it becomes something serious. It's significantly affecting quality of life.
Yes.
It's affecting your marriage. It's affecting how you interact with your family,
Socially.
your
Yeah, of
friends,
course.
everything. And, people are like the extreme ones, extreme cases of it. They're breaking down in tears in the office and like, please help me,
Yeah.
And so that's what we're trying to do is at the very least decrease the amount of times that it's happening so that you can live a semblance of your normal life.
Yeah.
And kind of if it happens a couple times a month, you just kind of deal with it at
deal
that
with
point,
it, yeah.
unfortunately.
No, it's interesting you say that because when I was doing my research about IBS for this, I actually found that There was even, do you see any type of correlation between people with IBS and who even develop like eating disorders because of it? Because they become, hardcore with just cutting thing after
Right.
thing out of their diet and they're down to this limited amount of, foods that they're consuming. Do you see that ever?
To a point, I wouldn't call it an eating disorder in the sense of like classic diagnostic eating disorders like anorexia or bulimia, but in terms of severely limiting your diet.
Yeah, very restrictive.
And then again, that kind of spreads out into the family and the friendships and stuff, which becomes tough to manage. That definitely happens. I haven't seen it, thankfully, to the point where there's like vitamin deficiencies or something like that, where someone needed to be hospitalized or something because of it. But it can definitely significantly limit what you feel comfortable eating. Yeah.
And for somebody who does experience IBS, I would imagine something like alcohol to be inflammatory for it.
It can.
It can,
Some
not
patients are like, I
necessarily.
can't touch a glass of wine. Some are like, beer just destroys me. It's very patient specific.
Okay.
And some can just have their cocktail, whatever.
And be totally fine.
Be totally fine. Yeah.
Okay. Is alcohol a stimulant?
I wouldn't like blanket statement say yes.
Okay.
Again, it's very patient specific.
Okay.
But if it's something that, some people just have a sensitivity to something in red wine, that could just ruin their day or their morning or whatever. So there are things like that, but not in terms of just alcohol itself causing an episode of IBS. I haven't had that happen.
Okay.
Yeah.
And do you think that our understanding of IBS has significantly improved over the years, or what research has led to our understanding of where we are now?
So we're at a much better place now than we were a decade, 2 decades ago. There's still a ton of work that needs to be done, and it is being done.
Okay.
It's just when will it become something that we can use and use well.
Okay.
Like the gut biome research that's being done is going to be, I think, crucial to this and to a lot of other diseases. Just the different percentages of the different bacteria that they note in everyone's different gut bacteria biomes. It's fascinating. They're kind of starting to realize, and they have been, that trying to alter those percentages seems to be fixing things in certain patients. And like we notice, there's a certain percentage of XYZ bacteria in Crohn's patients or ulcerative colitis patients or hopefully IBS patients. We can find something that's a little bit more data-driven and factual that we can claw onto, because right now it's just mostly trying to get people to relax and de-stress and change their diets and take a probiotic and reset the gut bacteria with a couple of different medicines. Otherwise, we're just treating symptoms and it's kind of masking.
Okay.
It's a little Band-Aid.
So you mentioned studying the gut biome. How do you actually study it? Is it through a stool sample? Is there a different test that you do?
So we don't do that.
It's
not something that's commercially done at this point, or widely done.
Okay.
It's just in research studies at this point,
Research
essentially.
studies. Okay, so that could be
For the most part,
the potential future. And how would you study someone's gut biome?
Theoretically in stool studies.
Okay.
Potentially in biopsy samples, like during an upper endoscopy or something like that.
Okay. Yeah. Interesting. Now, do common medications that are over the counter, do they put a Band-Aid on digestive ailments?
Pretty much. I mean, you're kind of treating the symptom. As long as someone comes in with diarrhea and cramping, as long as it's not an infectious diarrhea, we'll test, make sure the stool isn't infected. They take like Pepto or Imodium or, there's other things that kind of help with the cramping, prescription medications that we can give.
Okay.
But it's kind of, you're just kind of trying to help them live, essentially, as opposed to fixing the problem. But in the meantime, we're trying to give them the tools and help them to fix the problem.
Yeah.
Buy-in is a little difficult sometimes, and commitment to that is a little difficult. But they also know, hey, I'm going to be strict with this. I feel much better, but I really want to eat this thing today, and I'm going to deal with it. Like that happens often, and it's okay.
Yeah.
Like you want to live your life. So that's totally understandable as well.
Okay. Perfect. Now, when a patient comes in for bothersome, gastrointestinal symptoms, how does their workup start?
It depends on the symptom. If they come in with just loose bowel movements, we want to check the stool, make sure there's no infection. If there's rectal bleeding along with it, we might recommend a colonoscopy or what's called a sigmoidoscopy, where we just kind of take a look just at the bottom end. If there's abdominal pain, things like that, we might start with imaging, a sonogram, or if depending on what the story sounds like, a CAT scan potentially. Blood work, physical exam, obviously.
Okay.
So that kind of helps guide the pathway of like which steps are we going to take next, things like that.
Okay. And when you're taking a patient's history, do you find that family history has a role in diagnosing IBS, or if there's any genetics at play that might be contributing?
It can. There's actually been some recent studies that show there's potentially genetic linkage, and they have found some genes that are mutated in certain patients who have it within the family.
Okay.
Again, that's kind of in its infancy.
Yeah.
But you'll hear from patients constantly, oh, my dad has a bad stomach, like that's what I have, or whatever, something like that. So does it run in families? Potentially, yes. Will we find a true genetic link? It kind of has already started a little bit.
Yeah.
Will it be for everybody, though? Probably not. I mean, I feel like everybody has some level of IBS.
Yeah.
It depends on how bad it is, how often it gets activated. Just on the nerves and stress side of things.
Yeah.
So
It all plays a
people are
part.
stressed out. You get butterflies in your stomach, or you have to run to the bathroom. So like that
is a form of IBS.
technically is IBS to a
Wow.
point.
Okay.
Not necessarily the kind that's bothering someone every single day.
Yeah.
But if we're still considering like nerve endings having to play with this and stress and anxiety having to play with this, it kind of still fits a little bit of that puzzle.
So it's interesting that being 2024, that this is still a fairly new, topic. How long has the IBS been around for, the actual term?
I would say a couple of decades now at least.
Yeah.
The terminology changes every so often and guidelines change every so often, but the disease state has been around for quite some time.
Yeah. Okay. I know you mentioned that it's, patient specific, but the diets that have proven efficacy in IBS, can you explain the mechanisms by which, these diets can cause or improve symptoms?
So the main thing that we recommend is that low FODMAP diet, which is, it's an acronym for a very, very long couple of words.
Okay.
But basically it's certain building blocks of food that are more easily digested by the body.
Okay.
So that's kind of what it breaks down to, is how easily can your body break this down? And when it more easily breaks things down, you don't get the byproducts that end up causing the constipation, the diarrhea, the gas, the bloating, the cramping. So really the mainstay right now is that low FODMAP diet, which is FODMAP, is how it's spelled. But that's kind of what we recommend.
Does that diet mirror like the Mediterranean diet a little bit?
Not exactly. Some of the stuff in the good column is the Mediterranean diet. Mediterranean diet was typically recommended. It was, from what I recall, the only diet that was scientifically proven to help with like weight loss and metabolic syndrome in terms of like a regular diet, not like crash dieting or intermittent fasting, keto, all that stuff. So those things work in their own ways. This was the only one that was like peer studied, peer reviewed, and was proven to do that. That was a while ago, so I'm not sure if dietary wise things have changed in terms of factually making those differences. But from what I recall, that was like the one on the boards, that like Mediterranean diet is the one for, but more so for weight loss and things like that, not necessarily for digestion.
Gotcha. So I'm not familiar with the FODMAP diet, but I'm very curious now. What are some of the good foods that are on this list?
So it's a little confusing, honestly. It's funny. I don't recall the exact stuff that's on both sides. The one thing that I do recall off the top of my head that patients see, it's the first thing on the bad side, and all of them freak out because it's onions and garlic. So they're just like, I eat this every day.
Yeah,
And I'm like,
that's in most dishes.
Exactly. Little things like that can affect dietary digestion.
Okay.
So it's interesting. The stuff on the good side and the bad side might be surprising for people. And I can email you the diet that we use, at the end of this, just so you can kind of take a look at it. But it's not as restrictive as you would think. And I think patients are kind of pleasantly surprised by that.
Okay.
Yeah.
Well, that's helpful.
Yeah.
And I'm sure, like you said, onions and garlic, that could make it challenging for a patient to go out to eat, because that's something that a restaurant would include in a lot of dishes. So it's good to know going in this good and bad, so to say, list of what to look out for to to maintain, some sort of balance in their lifestyle. Yeah, of course. Okay. So like we said, the symptoms of IBS can be unpredictable and they can fluctuate. Sometimes food bothers a patient, another time they tolerate it fine, which can be confusing, I'm sure. If they remove it from their diet and restrict it more, we could see, I guess, these consistent food triggers like you mentioned. So you would say that the food diary is the best way to kind of monitor this?
I think so, because otherwise you kind of just forget,
Yeah.
and it melts into your day. Forgot what you had for breakfast, or like what specifically you had for breakfast or lunch or dinner.
Yeah.
Did I feel bad this day? No, it's Friday. And I'm like, oh, what happened on Monday? Like, was I all right? I don't remember. It was such a busy work week, whatever. I think it's just a great way to keep track of things.
Yeah.
I have to write everything down myself. So like I'm very much an advocate of doing that, because
Okay.
otherwise you kind of forget.
You can see.
Put every tiny thing in my calendar and like little notes for myself and reminders, because that's how things just work easier for me. Not everyone's like that.
Yeah.
If you have that memory where you remember everything perfectly, phenomenal. I feel like a lot of people aren't like that.
Yeah.
So that food journal does help a lot.
Okay.
Yeah.
And I'm assuming, do you tell your IBS patients to avoid things with caffeine because that could be a stimulant?
It can, especially like highly caffeinated stuff. Anything caffeine, nicotine, alcohol.
Yeah.
Typically bad for IBS, typically bad for reflux, so which they kind of go together, bad for dyspepsia. So all of those things can kind of melt into each other a little bit. So
Okay.
that's part of the problem, is like, are you treating one specific thing, or are you treating a couple of things at once? So it's good to kind of try to play around with it enough where you're hitting a couple of different things and hoping that that stuff is what's going to make them feel the best at this point.
Okay. Now, somebody who has IBS, if they get a colonoscopy, or what's the other test that you...
Like an upper endoscopy, the
Or,
camera.
yeah, and the other one.
The sigmoidoscopy?
Yes. Do you see something different amongst IBS patients compared to a regular
No.
patient? No. So
And
there's
that's
no...
why, so technically, they changed the guidelines.
Okay.
A few years back, you could not diagnose someone with IBS without doing an endoscopy and colonoscopy.
Okay.
Because you have to rule out like 4, 5, 6 other diseases before you can say, this is probably IBS, because it's a diagnosis of exclusion. There's no test that tells us you have IBS.
Yeah.
It's just, these are the symptoms I'm having. Meanwhile, these symptoms can be symptoms of inflammatory bowel disease, acid reflux, dyspepsia, colon cancer, so all of these things,
You're ruling
we just
out
have to make sure
first.
these things are not happening. Are they likely? Depends on the story, depends on the other symptoms, what's going on, what does the blood work say,
Yeah.
what does the other testing say. So they kind of shied away from that a little bit, and then the recommendation was kind of changed to, let's try medical treatment first for like a month or two, if they stick to it.
Yeah.
So if it's helping, great. We're most likely suffering from IBS or something similar. If it's not helping, probably need a colonoscopy and endoscopy at that point to just rule out things like the celiac and all that other stuff we talked about. Yeah.
Do you see a correlation between IBS patients? Do they oftentimes also suffer from acid reflux?
I would say a lot of people suffer from acid reflux, so probably. Whether it's silent reflux or they actually feel like the heartburn coming up and the indigestion. Some people just have a little dry cough, and that's from a postnasal drip from inflammation up here from acid, that they don't necessarily feel like they're having heartburn, like the classic heartburn.
Yeah.
So I would say probably, but there's no like direct link.
Okay. I know a lot of pregnant women, myself included, suffered. My older daughter sat, I felt like very high, and I was a big sufferer of acid reflux. Do you see pregnant women ever for IBS? Does that something that can present itself during pregnancy?
It definitely can. I feel like we only get referrals with pregnant patients once the OBGYN has kind of run out of what they're typically using to treat.
Yeah.
Which is not often. So rarely.
Okay.
Or there's a concerning blood work or something like that they want just a second pair of eyes on.
Yeah.
But there's so many changes that happen during pregnancy that certain things are normal. They show up as abnormal, but it's normal for that time frame.
Of course. Yeah. Okay. Is there a certain age range that you do see presenting more than others for IBS? Is it younger or older?
Everybody, honestly, is prone to it. But I would say, especially now, younger overall.
Okay.
more stress, more job-related stress, more family-related stress, more financial stress, typically in the younger groups at this point, from what we're seeing at least.
Yeah.
And that's kind of a big piece of the puzzle with IBS, it feels like.
So stress is a big factor.
Yes. Like I always recommend to most of my patients, honestly, take like 10, 15 minutes a night to yourself, pull up like a YouTube breathing or meditation video, sit in a dark, quiet room.
Yeah.
Just kind of clear your mind every night if you can.
Yeah.
A lot of people can't, or they just can't, they don't make the time,
Yeah.
But if you can, in general, that's good for your body. In general, that's good for your nervous system, which eventually means it's good for your GI tract.
Okay. That makes sense. So, as you mentioned before, there is an explosion of research about the microbiome. Can we alter the microbiome to optimize patient outcomes? And, what would you say is the role for interventions in targeting the microbiome for IBS?
So eventually, I think we'll be able to alter it with like precision, which will be amazing.
Okay.
I don't see that happening for probably another decade or two, depending on how this goes,
Yeah.
how quickly these breakthroughs come.
Okay.
But we still try to alter it now, and that's probiotics.
Okay.
So over-the-counter probiotics, we typically recommend like Align, Florastor. There was a prescription one called VSL number 3
Okay.
that was only for patients with inflammatory bowel disease, or that was the recommendation. Now it's over-the-counter.
Okay.
So those are the 3 big ones that we recommend. If you can't find one of those, just anything over the counter is better than nothing. You can get it naturally in foods like kimchi, those cultured yogurts like kefir
Yes.
yogurt, things like that.
Okay.
Sauerkraut. We try to kind of force the gut biome to change by taking either those pills, gummies, or foods.
Those foods, yeah.
There's also a medicine that we can use. It's a non-absorbed antibiotic that
Okay.
you take 3 times a day for 14 days specifically for this, for more for the gas, bloating, diarrhea predominant IBS patients. And that essentially, since it's non-absorbed, it just rides the gut and tries to kind of knock out the current bacteria. And we try to take that probiotic with it and kind of reform your gut's bacterial memory, essentially. And for a lot of patients, you're getting like 6 to 12 months of relief with that.
Wow. So that's
And
helpful.
some patients are lifelong, some couple of weeks, but
Okay.
it's a really good alternative to have.
Yeah.
I'll see them back like a month or 2 after we've tried dietary and stress and all that good stuff. And if it's not taking as strong a foothold as we want, we'll try that medication.
How do
It's
you feel
interesting.
about something like kombucha? I feel like that's become a more popular drink. Is that giving good probiotics to people?
So I'm okay with people trying whatever they want,
Yeah.
as long as it doesn't make them worse, and as long as it's not something herbal that we know causes a problem,
Okay.
which is not common. But I'm all for that stuff. I try not to discourage people from trying things like that
Yeah.
because you want them to be able to feel like, they can try different things, see how it makes them feel, that you're on board with it. I want buy-in from my patients. I try to discuss things with them and plan with them as opposed to like talking to people. So that does help a lot. And kombucha is good. Patients have their own alternatives for a lot of different things. I'm like, try it. That's totally fine. Just report back,
Okay.
make sure everything's okay. If it's something that I know is known to cause like another specific problem, I'll just warn them about it, and we'll kind of go from there.
Got it.
Yeah.
Makes sense. Now, in your experience, do patients ever experience any major adverse effects from trialing probiotics?
Just some people, it doesn't tolerate.
Yeah.
They don't tolerate it as well as someone else might have.
Okay.
So those are the ones that I kind of ask them to
Just
switch
to
it up
switch it
or
up
take a
and
break
take a
and
step
switch it
back.
up or something like that.
Okay.
Yeah.
And now, what key messages about diet and IBS would you like to convey to the audience, and what do you see for the future?
I mean, right now, what I would say is it's a complicated puzzle. So work on each of those pieces as much as you can.
Yeah.
Between dietary, between stress management, between lifestyle stuff that you can do, and the probiotics potentially. The future, I think, is super bright for this.
Yeah.
I just hope it comes sooner rather than later, and we'll have a lot
Get some more
easier and
relief.
better ways of
Yeah.
helping people.
Yeah. Do you think
improve
there'll
their
be
quality of life.
more prescription drugs or?
I think it will probably be more specific gut biome testing.
Testing. Yeah.
And trying to alter that as much as we can. In the meantime, there are prescription drugs to help with the symptoms.
Yeah.
So that's good. We have those at our disposal. They don't always work or work as well as we would like them to, but at least we have something, and they do miracles for some patients. So
Yeah. Well, that's
it's
helpful
good to
to
have
know.
something.
Of course, of course. Well, I would like to thank you once again for all that you do to keep us safe and healthy and for joining us today.
Thank you.
So that about does it for this episode of RUMC Connections. For more information about gastroenterology services or to schedule a consultation with Dr. Shanazarian, please feel free to call 718-448-1122 or visit rumcsi.org. Thanks for joining us. I'm Meredith Gaskins.